evening, everyone, and welcome. Those of you on the West Coast, good afternoon. Would like to welcome you to part one of our very exciting webinar series on managing side effects and prostate cancer treatment options with risk mitigation for radiation therapy. Today's webinar is brought to you by Zero Prostate Cancer and sponsored by our partners at Boston Scientific. My name is Shelby Monier, Vice President of Patient Programs and Education here at Zero, and I'll be serving as your webinar moderator. And I want to thank our featured speaker, who I'll introduce momentarily, Dr. Dean Laganosky, for sharing his time and expertise with us today. Before we begin, I would like to go over just a few housekeeping items. Our webinar today is being recorded. It will be available on our website, and you'll receive it in an email that will ask you to participate in a post-webinar evaluation. So please give us that feedback on this event, and we'll also give you the opportunity to share some topics that we can help provide to you in the future. You'll receive an email tomorrow with the link to the recording and with that survey as well. So just a bit about Zero Prostate Cancer. If you're new in learning about Zero, Zero is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. We are proud and thrilled to offer a lot of patient support programs and educational tools, all of course, which are offered at no cost to patients or their families. So if you or someone you know is in need of any resources or support or information at any time while facing a prostate cancer diagnosis, please share these resources. Let them know that there is someone else in their corner. We are here to help. So I'll go through these pretty quickly, but I wanted to share just a bit about these programs. Zero 360 is really our flagship case management program. This program pairs patients with a trained case manager to help them and their families connect with financial assistance programs, navigate insurance, and really find a lot of different support tools, including emotional support and transportation assistance. So this is a great program if you want to be paired with a one-on-one case manager. We also offer two peer-to-peer type support programs. The first is our mentor program. So this program makes one-on-one connections, matching patients with other survivors who want to provide that emotional support. We also provide group support in a peer-to-peer fashion through our Us2 support group. So please take a look at our support group finder tool. It's on the Zero website, and you can find a virtual group or a group that might be right in your backyard. If you like virtual support, if that tends to work better for you, you can also connect with other patients and survivors and caregivers and family members of those diagnosed through Zero Connect, which is our private Facebook group. In addition to Facebook, we have a prostate cancer community on a platform called Inspire. This is an online patient forum. We have more than 30,000 community members in that community. So you'll really find that a welcoming place to network and ask questions and find additional information. And last, but certainly not least, I want to invite you to part two of today's webinar series, which is tomorrow, November 29th, when we'll be discussing prostate cancer treatment side effects and how to manage them. So side effects like erectile dysfunction and incontinence. And many of you who are here with us today did register for both of those. But registration is still open if you did not register for that second part, or if you would like to share that with others. So I want to thank our sponsors once again at Boston Scientific, edcure.org, and introduce you to our featured speaker this evening, Dr. Dean Laganosky, a urologist at Mid-Atlantic Urology Group. Dr. Laganosky has received recognition as a National SpaceSource Center of Excellence provider for prostate cancer radiation therapy management. And just a note, we will take questions from our audience throughout this webinar. You can submit them at any time And we will take those questions at the end of our presentation, and we will get to as many of those as we possibly can. So if you have questions throughout the presentation, be sure to type those into the Q&A box. It's located at the bottom of your screen. And with that, Dr. Laganosky, I'll now pass it to you to get us started. Thanks for being here.
Excellent. Thanks so much, Shelby, and great to be with you all tonight. Thank you for taking the time to spend with us so we can review a very important topic in prostate cancer management, but also mitigation of side effect profile. So again, I'm Dean Laganosky, our urologic oncologist specialist with Mid-Atlantic Urology in Philadelphia, part of Solaris. I'm going to walk you through an overview today of not only prostate cancer, the prostate gland anatomy, but also some options that we have available in terms of treatments and side effect mitigation. So we're going to start out by doing an overview here. We're going to first go over prostate cancer and prostate anatomy. We'll then go over treatment options, radiation therapy, and rectal spacing options, which can significantly help to reduce many of the complications associated with radiation, sometimes prostate cancer management. And then what's the next steps for individuals undergoing prostate cancer diagnosis and treatment may be. We'll have a good amount of time for questions at the end. So as Shelby said, please submit those throughout and we'll make sure that we answer those at the end. So a prostate cancer overview. Prostate gland, in general, is a walnut-shaped ball that sits around the tube you pass the urine out of through the bladder. So on the image to the right, you have the bladder that holds the urine as a reservoir. The prostate gland is basically located right below that as the pink circle. And the urethra, the tube where the urine flows, travels right through the middle of the prostate gland. It's primarily responsible for ejaculatory function and supporting the sperm for fertility purposes. It's also a common site of urinary tract cancer with prostate cancer. So there are several things that can affect the prostate gland. One of the more common etiologies is a benign growth of the prostate gland. This is called BPH, or benign prostatic hyperplasia. It is common as men age that our prostate glands are going to grow with us. Some individuals' prostates grow larger than others. And if you use that analogy of the ball that surrounds the urinary tube, as it grows, it may compress upon that tube and make a smaller channel where the urine will flow. Sometimes this can translate to symptoms associated with BPH, including a more difficult time passing urine. So if you look at the diagrams on the side, you have kind of what the normal prostate anatomy would look like before it grows. The bladder is squeezing with a certain pressure to push that urine against the prostate and is able to empty reasonably well, compared to screen right, far right, which is an enlargement of the prostate gland. In this type of situation, the bladder muscle has to really squeeze much harder to generate that squeeze to push that urine out against the prostate gland. That's a situation that can cause symptoms of frequency, urgency to go to the bathroom, nighttime and daytime urination, and in some situations, retention of urine that may require catheters or other issues. It's important to note that BPH, or benign growth of the prostate, is not prostate cancer. It's also important to note that even individuals with large prostates or small prostates can get prostate cancer. So it's important to meet with one of your providers or a urologic specialist to really go over screening protocols and how we can better identify if there is a need to look into screening or treatment options further. Having an enlarged prostate gland does not necessarily mean that you are at an elevated risk of having prostate cancer. And it's important to note that both enlargement of the prostate and prostate cancer can cause similar symptoms. So again, highlighting the importance of meeting with an individual who can help you in the medical field if you are experiencing anything like weak urinary stream, difficulty starting or stopping, or an elevation in your prostate-specific antigen, which is a blood screening test for prostate cancer and other prostate issues. So it's important to note that prostate cancer is one of the most common cancers affecting men after skin cancer. That being said, prostate cancer overall 5-year survival rates are very good because of a lot of the advances in therapies that we can offer patients. 98% of individuals have good, durable 5-year survival rates. So prostate cancer in the United States in modern data sets. 288,000 individuals were newly diagnosed with prostate cancer in 2023. 34,000 individuals have died of prostate cancer this year alone. 5-year relative survival rate for prostate cancer that is confined to the prostate gland is 99%. And then 5-year all stage survival related to prostate cancer is 97 to 98%. It's also a really striking statistic when you note how common prostate cancer is. If you had 8 individuals in a room, at least one of those men would be diagnosed with prostate cancer over the course of their lifetime. There are certain risk factors that are associated with prostate cancer development. As we increase in age, there is a higher likelihood of detecting prostate cancer, particularly in individuals of average risk over the age of 50. So again, important to make sure that you're meeting with a healthcare provider to do the appropriate screening. Over half of prostate cancers are found in men older than the age of 65, but there are some prostate cancers that may be detected at much earlier ages. Genetics may play a role in prostate cancer development. It's important to state that most individuals who develop prostate cancer do so sporadically, so may not have a family history of prostate cancer, highlighting the importance of getting screened even with no family history. But having a father or a brother, first-degree relative of prostate cancer, may increase the risk by twice. There are certain race and ethnicity predispositions to prostate cancer as well. Compared to white men, Black men are 1.7 times as likely to develop or be diagnosed with prostate cancer. And Latino and Hispanic men are 21% less likely to receive treatment. So the most important thing is detaching the stigma associated with getting screened and meeting with a healthcare provider, because many of these decisions and these conferences with a healthcare professional can make a big impact on your health long term. There are some lifestyle and behavioral risk factors as well that can increase the risk of prostate cancer. Things like inflammation of the prostate gland, some chemical exposures, and sexually transmitted disease may be associated with an elevated risk of prostate cancer in some circumstances. Early detection is key. So by many of the guidelines, including the American Urologic Association, you should start talking to your doctor about a shared decision-making approach to prostate cancer screening for men of average risk, meaning no elevated family history of prostate cancer or other high risk factors around the age of 50. Some men may be appropriate for screening a bit earlier. So men at high risk for developing prostate cancer, Black men or men with a father or brother, first-degree relative with prostate cancer, may start screening at the age of 45. And men with even higher risk, multiple relatives, first-degree or otherwise with a history of prostate cancer, may need to start screening around the age of 40. Screening refers to a detection of prostate cancer in individuals without symptoms. Prostate cancer is a disease that can occur very silently in the background. If testing is not performed, many individuals may not have any associated symptoms related to their prostate cancer development until more advanced disease is noted. Hence, the importance of getting screened. There are 2 common ways that we as healthcare providers look for prostate cancer or screen for prostate cancer. PSA, which is prostate-specific antigen, is a blood test that looks at levels of associated protein from the prostate gland. It's a simple blood test. I typically will state that PSA, or prostate-specific antigen, is prostate-specific, but not cancer-specific. So there are other things outside of prostate cancer, including enlargement of the prostate or inflammation of the prostate, sometimes certain activities that can cause PSA to be higher than usual values. It's important to interpret these values and work with your healthcare professional to figure out your individual risk and next steps in management. And then digital rectal examination is a quick finger exam of the prostate gland that's done in the office. It takes about 1 to 2 seconds and can detect any irregularity on the surface of the prostate. It can sometimes find prostate cancer in men even with normal PSA values. And if the results of any of those tests are abnormal, additional testing or diagnostics exist that help to clarify, is there anything to look into further or potentially target with a biopsy. This is an imaging study. MRI, or multiparametric MRI, looks at cross sections of the prostate gland in a non-invasive fashion. It can really grade the tissue to determine if there are any areas of the prostate gland that look more irregular or should be targeted with a sampling of that tissue. And an ultrasound of the prostate gland is sometimes used to also visualize the prostate gland, particularly in the setting of sampling of the tissue. Genetic testing may be appropriate for some individuals who are at higher risk because of their family or other risk factor, family history or other risk factors. And then some individuals may have prostate cancer detected in a non-screening fashion, meaning they come for symptoms associated with urination, and then through that workup, when they are symptomatic, have findings that may be concerning for prostate cancer and have the other diagnostics to confirm this. So diagnosing prostate cancer, a prostate biopsy is really the most definitive means of looking at the tissue or assessing that for underlying cancer or malignancy. This directly looks at small needle punctures typically that are taken from the prostate tissue in a targeted or a templated fashion. And we have our pathologists run staining or testing on that tissue to determine if the tissue is consistent with cancer or non-cancerous process. This is either done through an ultrasound-guided transrectal approach or transperineal biopsy, which is small needle punctures on the skin surface underneath the scrotum, either with some sedation or in some cases under local anesthesia. Pathology report, again, would show us directly if there is cancer or no cancer and would help to clarify some of the other testing that's been done. So it also, in terms of taking a tissue sample, can help to determine the severity of prostate cancer. So if prostate cancer is detected, it's important to know how it is graded and how it's staged. So non-metastatic or localized prostate cancer to the prostate tissue is graded typically with a TN and M staging. This is the most common cancer staging system, which we'll go over in a subsequent slide. And then the Gleason score or grade grouping score are ways that we look to see how irregular the prostate tissue is, that cancerous process compared to regular prostate tissue. Is it more irregular or more aggressive, or more behaving like indolent disease or regular prostate tissue? Other factors that will help to grade severity include PSA levels, imaging findings of disease confined to the prostate or elsewhere, exam results, sometimes genetic testing that can help to guide decision-making, the volume of tumor that's present, and other risk factors and laboratory evaluations. So TNM staging is not only used for prostate cancer, but other cancers around the body as well. We typically grade between 0 and 4. T refers to the tumor and how much of the prostate tissue in this case is involved. If it's on both sides, how that's diagnosed, what's the volume of tumor within the prostate gland. N refers to any spread of that disease to the lymph nodes and where those lymph nodes are involved. And then M is any presence of metastatic or spread disease past some of the local lymph nodes. Based on what that staging is, there would be different treatments available to you. And for prostate cancer, urologists also use Gleason grading scores or systems. So the Gleason score and grade group scoring for kind of newer models here basically looks at the tissue under the microscope and says how irregular is that prostate cancer compared to typical prostate tissue. We have the pathologist look under a microscope and grade and give a score for what the most common pattern of that prostate cancer is. That gets the first score in the Gleason grade, and then what the second most common pattern is. Those two scores are added together, and then you come up with a cumulative score, which is a Gleason 6, where you see 3, which is the most common pattern, plus 3 secondary pattern. So scores of 6 are kind of the most like regular prostate tissue. In low volume cases where PSA is normal and some of those other risk factors are low, this can represent very low or low risk disease. Prostate cancer then in some situations may be amenable to just watching and may not require an active treatment. Some of those cases, though, may actually need to be treated, and each case should be discussed with your healthcare professional. Intermediate risk disease is a score of 7. Most of these cases are requiring some type of treatment, which will go into different options as we go forward. And then higher risk or very high risk disease scores of 8, 9, or 10 typically require other considerations, including active treatment, sometimes multimodal, or a couple different options for treatments. Grade group score, just a brief note on that, is a score of 1 to 5, similar to the Gleason score. A score of 1 is kind of lower risk or kind of more normal appearing prostate cancer tissue. A score of 5 is kind of more aggressive or irregular prostate tissue typically. So what are some treatment options for prostate cancer? So there are options for some individuals to watch their prostate cancer. This is active surveillance. It involves checking on routine time periods or intervals to make sure that your levels of PSA, imaging studies, and biopsies are not changing. And if the disease is staying stable, as long as that's being watched, we know objectively that we may not need to consider other options for active treatment, can be watched over time. Removal of the prostate tissue can also occur with surgery, typically done through a robotic approach, which we'll go into. And then there's radiation therapy options for directed beams of radiation or other types of radiation to destroy prostate tissue and prostate cancer cells. Other treatments include hormone therapy, chemotherapy, freeze therapy or cryotherapy, high intensity focused ultrasound, which is an ultrasound directed to destroy prostate cancer, immunotherapy. These are therapies that work with your immune system to target prostate cancer, and other targeted therapies, which we'll go more into. Active surveillance. So in general, lower risk or kind of more indolent diseases of the prostate may be more amenable to watching prostate cancer. Not all prostate cancers can be watched, but these are typically selected through work with your healthcare professional to determine which prostate cancers actually need treatment versus ones that can be safely watched. And if we are seeing any objective changes over time, we can pivot then to an active treatment if needed. This is typically monitored with PSA blood test at set intervals, whether that be 3 or 6 months, digital rectal examinations, imaging, and sometimes repeat biopsies to confirm under the microscope the disease is not changing. Benefits of this are there's really not any treatment side effects from doing this. However, it's important to note that this is not an ideal option for management for individuals with more aggressive or changing cancers over time. Surgery is typically done with a removal of the prostate tissue and sometimes some of the lymph nodes around the prostate where prostate cancer could sometimes be found. This is typically done in older times with an open surgery with a larger incision. Nowadays, the gold standard has really evolved towards a laparoscopic or robotic surgery to remove that prostate tissue. This is done through small incisions on the belly area. Through a 3 to 4 hour surgery, typically an overnight stay in the hospital. It does require general anesthesia. There is a recovery period, sometimes on the order of about 4 to 6 weeks. This surgery sometimes does require a catheter to allow the tissue to heal after the prostate tissue has been removed, typically for about a week. But it can be invasive in some situations and, have side effects associated with it, specifically a risk of leakage of urine. When the prostate gland is removed, we try to spare the nerves that supply urinary control and also erectile function. But in some situations, you may have a weaker erection or less rigid erection, decreased ejaculation, or difficulty controlling urine, all of which can be addressed with different options depending on the severity of that moving forward. And then radiation therapy exists in a couple different options. External beam radiation therapy, or EBRT, is a delivery, non-invasive delivery of a radiation beam focused to the prostate tissue that destroys cancer cells and deactivates the active cancer cells. This is delivered from a machine from the outside of the body, and there are different types of forms of external beam radiation therapy. It's generally done as an outpatient, a few treatments a week over the course of a 1 to 2 month period. Each plan for radiation is tailored by a radiation oncologist who would work with you throughout that treatment. Side effects, again, can be urinary issues, including leakage of urine, sexual side effects, erection issues, and ejaculation issues, and in some situations, bowel-related issues due to that radiation affecting some of the structures around the prostate gland, including looser stools, blood in the stool, rectal urgency, or leakage of stool. Other options exist in terms of radiation therapy. There is brachytherapy, which is a delivery of radiation seeds that emit a radiation to the inside of the prostate gland. These are typically implanted as pellets within the prostate through a minimally invasive procedure. Other options are a delivery of a liquid radiation into the prostate gland, again through the direction of a radiation oncologist and your urologic oncology specialist. This is not as commonly used as external beam radiation therapy and may be appropriate for some types of lower risk prostate cancer or intermediate risk prostate cancers, may not be the most effective option for higher risk cancers. So other options exist for radiation therapy. There are a number of different ways that you can direct or focus that radiation beam. There's 3D conformational imaging, intensity modulated radiation therapy. This is a higher dose of radiation delivered over less sessions to the prostate gland. Image guided radiation is a similar technique. Stereotactic body radiation is really high intensity, kind of much lower fractionated radiation therapy delivered to the prostate tissue. And there's proton beam radiation therapy, which can be sometimes a bit easier to direct or try to reduce the spread of those proton or active photons that are treating the prostate cancer. You have high dose and low dose radiation therapy, which is either brachytherapy, which is a liquid radiation, or a pellet radiation into the prostate gland as well. Other therapy options, including freeze therapy of the prostate gland, which is cryotherapy, used to freeze cancer cells and destroy them in that fashion. Immunotherapy is therapies that are engaged with your immune system to target cancer cells that may be appropriate with some types of prostate cancer. Hormone therapy works on many of the growth signals to prostate cancer, reducing things like testosterone, which would help to reduce the risk of prostate cancer growth signal when you are getting therapy or alone as a monotherapy. Targeted therapies, there are some genetic targets that can now be focused on for treatment of your prostate cancer. Chemotherapy may be appropriate with some higher risk prostate cancers, and focused ultrasound delivery to the prostate tissue may also be an option for some individuals with prostate cancer. So, knowing that radiation therapy, similar to surgery, has its side effects and potential to affect some of the structures around the prostate gland, we've really made advances in terms of trying to mitigate or minimize some of those side effect profiles. Hydrogel, which is a rectal spacing option, is a minimally invasive option that will really help to protect or provide a shield for most individuals getting beam radiation or seed implant radiation therapy, to keep that radiation beam focused to the prostate tissue and not the surrounding structures. So as you can see on the screen right, you have your prostate tissue, which is highlighted in red. That's really where the beam or dosing is focused for prostate treatment with radiation therapy. You can see some of the green and the blue rings show that not all that prostate radiation that we intend to go to the prostate gland is really completely confined to the prostate in many cases. And the space that's highlighted in the back of that blue ring, where you can see some of the black splotching on the image, is the rectum, which sits directly behind the prostate, with the prostate really sitting directly on top of that structure. The rectum is an organ at risk when you receive radiation therapy for unintentional spread of that radiation to that structure. And rectal toxicity can lead to loose stools, bloody stools, painful bowel movements, frequency, urgency, or leakage of stools that can occur in the short term or long term after radiation therapy. Rectal spacing has been a very effective therapy that is done preventatively or preemptively before radiation therapy to protect the rectal structure and some of the other structures before radiation therapy is delivered. In one of our studies, including pivotal data, which is a longer-term, multi-institutional randomized control trial, 551 individuals underwent radiation therapy for prostate cancer. And of those individuals, 269 received the rectal spacing option. You can see, as the data sets are presented over to the right, that those individuals on the blue columns that received the rectal spacing option had a 5% decrease in rectal or gastrointestinal side effects of that radiation therapy, and 15% of individuals, had far fewer genitourinary or urinary tract side effects or sexual side effects associated with the radiation therapy, compared to about 32% of individuals who did not receive rectal spacing. So what is hydrogel? This is a water-soluble PEG solution that is basically two liquids that combine to form a gel, or that can be put in through a small needle puncture. This is typically done in a minimally invasive, quick 10-minute to 15-minute office-based procedure, and is generally more well-tolerated than any biopsy. We target this gel into a space to lift the prostate gland and act as a cushion between it and some of the structures behind it, including the rectum. It's designed to really reduce radiation therapy delivered to the rectum and minimize the side effects of radiation. On average, it can create an additional 1.3 centimeters of space, lifting up that prostate and separating it from the rectum and other structures, which is a big amount of space when you're talking about minimizing radiation spread from the prostate to the other structures. This is a soft material that is actually broken down into water and then urinated out, typically 3 to 6 months later. Does not require any type of removal with the procedure. It's a brief, well-tolerated outpatient procedure under local or sedation anesthesia, and it naturally leaves your body and is broken down into water. The data is robust, and rectal spacing really, in most practices, should be the standard of care for individuals receiving radiation therapy to their prostate, in terms of better quality of life for patients undergoing radiation therapy and safer, minimized side effect profiles. So there are fewer bowel complications at 3 years following treatment. Patients who got rectal spacing experienced 75% less grade 1 rectal toxicity, less urgency, loose stools, frequency, bloody bowel movements, or leakage of stool, fewer urinary complications, and better urinary quality of life by about 60%, and fewer sexual side effects associated with radiation therapy due to that increased protection. This is used in more than 500 cancer centers around the world, and thousands and hundreds of thousands of patients have received this therapy safely in anticipation of their radiation therapy. So we're going to watch a video here, if I can get this to play, of Dr. Gray, who is both a provider and a patient who has received SpaceOAR hydrogel. I'm having a little bit of difficulty playing that, but we'll make sure that we send out the video along with the recorded webinar, so you have the ability to hear Dr. Gray's perspective, which I think is very powerful. As an individual who would typically see patients coming through with prostate cancer who underwent radiation therapy, hearing both the provider and the patient perspective and hearing their positive experiences, I think really speaks volume to the trust that many healthcare providers put in this for patients undergoing prostate cancer radiation therapy. So in summary, radiation therapy, similar to surgery, can be very effective for treating most forms of localized prostate cancer, but there are potential side effects or risks. The prostate gland sits very close to the rectal tissue and can be affected by unintentional spread of that radiation beam or other seed therapy to the structure surrounding the prostate. The goal of a hydrogel or a rectal spacing is to temporarily create a space that shields the prostate gland when it gets radiation therapy from the surrounding tissue structures. Reducing the dose of radiation and the unintentional spread to the other tissue contributes to better quality of life and protection to minimize side effects of radiation. So, next steps, and many individuals who have heard me talk on this subject before know the emphasis that I place on engaging with your healthcare provider and coming up with a plan side by side with their expertise and what your treatment goals are. When somebody comes to see a urologist such as myself, my goal is to really engage with you, to make you understand as much as I understand about prostate cancer and your specific risk factors and what may be going on with your disease process or your screening. We should engage with each other and come up with what we think is the best plan together. And it's important to know that even if you've been diagnosed with prostate cancer, you're not alone, and you have many, many great resources out there. The American Cancer Society, Zero Prostate Cancer, does amazing work in this space and has many of the resources that Shelby mentioned earlier. And the Prostate Health Network, as well as your local urologist and oncologist. It's important that you engage with us. Let us help you through this process and have conversations with other individuals around you who may not be getting the appropriate screening or may be hesitant to meet with a healthcare provider. There are ways that we can work with you to really make sure that we keep you nice and healthy and work together to make sure that we're treating your disease and keeping you healthy for years to come. So know your risk level, meet with a healthcare provider, talk to your doctor about screening if you have not, particularly if you have risk factors, and then learn more about treatment options with all these great resources.
Great. Well, thank you. I just have to say it was wonderful that you gave that background of prostate cancer, because we have such educated patients in the zero prostate cancer community, but I think it really set the stage, and we actually got several questions about kind of just general diagnosis, metastases, those types of questions. So if it's okay with you, I'll start with a couple of those. They kind of came in toward the beginning of your presentation. So I'll try to go in order, but forgive me if we bounce around a little bit. But just another thank you for such a great presentation.
Sure.
So the first question that came in was kind of just a general basic question about how and why prostate cancer generally spreads through, outside of the prostate gland.
Yeah, so very good question. So prostate cancer can spread not only within the prostate tissue, locally spreading from one cell to another, but also can sometimes spread through some of the blood vessels and some of the small lymph tissue, which is normal immune tissue in the body. And when we look at prostate cancer and where that is involved, some of the screening that we have available, imaging studies, MRIs, may help to show us exactly where that prostate cancer is. And that would help us to target a more tailored management plan for you as an individual. So it can spread both locally and through some of the smaller blood vessels outside of the prostate tissue.
And the next question that came in is about BPH symptoms, and this person is wondering if those types of symptoms can be treated at the same time as prostate cancer can be treated if they both are occurring. or if that treatment for BPH would need to be postponed until other side effects might be resolved.
Another very good question. So the answer is there are options to treat around the time of treatment for prostate cancer. There are situations where we preemptively may treat voiding issues beforehand, depending on what types of treatments you're going forward with. For instance, if you have a large prostate gland and you have been diagnosed with a prostate cancer that would require treatment, and you did a surgery, you are removing the bulk of that blocking tissue from the prostate gland. So that may actually help both with the symptoms of urination as well as treat the prostate cancer. If you are getting a radiation where that prostate gland would be staying in place, some options exist to treat the blocking prostate tissue in a very minimally invasive fashion or with medications prior or alongside the radiation therapy to help with the voiding along with the prostate cancer treatment.
Okay, that's great. Yeah, that was a great question. I agree. The next question is was an animated question. But this individual is really asking about a PSA of under 7, so about 6.8, and this is very specific, so I won't get much more specific than that. We don't want to act like we can diagnose or treat in a webinar. But 6.8 PSA, and the Gleason is low, but this patient is concerned about the advice that was received from the doctor, which was to wait 6 months to see what happens, kind of that watch and wait option. And so maybe you could speak to, again, not knowing that you are not seeing this patient, but just speak to that time frame, whether or not that's reasonable, and if that person should seek a second opinion, just general thoughts.
Yeah, absolutely. So in general, I never discourage second opinions, and I never discourage, I think there's no harm in meeting with individuals to talk about different strategies for how to manage what you have going on from a healthcare standpoint. So that would not be out of the question. The reality is that, watchful waiting or active surveillance, right? It can cause anxiety for many individuals, and it may not always be the right option for you. And it's important to engage with your healthcare provider and work alongside them to come up with what the best strategy may be. Even if you have low risk disease and you wanted an option to potentially take that out of the equation or treat that, go over some options, what that would look like in terms of cure rates, which should be very good for low risk disease, and what types of options may be best for you. One of the benefits of active surveillance is that you don't have to have a surgery and you don't have to have a radiation therapy, which doesn't come with some of those side effects or some of the therapy options that we talked about. But again, not the best for everyone from that standpoint. So, to answer your question, is that the right approach? It is a common approach to watch that. However, if that's not seeming like it's the best approach for you, may be beneficial to re-engage with your provider and then come up with what we think is a better kind of shared decision-making approach together.
Yes, thank you. The next question is about an individual who had initial biopsies many years ago. And the patient is just more recently presenting for treatment. And this person's wondering if another biopsy needs to happen, or how that might tie into radiation therapy generally.
Yeah, so what I would answer there is it depends on if there needs to be an update in terms of what the disease looks like. If a new biopsy is going to change the management in terms of the current therapy plan for radiation, or if that's not necessary to really treat the type of disease that they were diagnosed with before. So although it's a little bit of a specific answer for your individual case, what I would typically advise you to do is have that discussion and say, listen, is a new biopsy or an updated piece of information helpful to help to clarify how we're going to tackle this or how we're going to manage this? I generally say, listen, information is power, and having some degree of objectivity to really guide your decisions is really key there.
Yeah, great advice. The next question is a fairly recent biopsy within the last couple of weeks, but this person is still experiencing some side effects with semen and urine having kind of still having some blood in it. And so this person is wondering if they're if that person should be alarmed, or how long is too long to experience that type of side effect.
Yeah, I mean, the reality is that with a biopsy, these are small needle punctures into the prostate gland. So I will typically counsel patients that in that setting, in the recovery process, you'll expect blood with most bodily functions: urine, semen, and stool, typically for a few days, but can linger for several weeks. The likelihood of any clinically significant bleeding from a prostate biopsy is very low. Transfusion rates far less than 0.5%. However, right, blood tinge can linger in many situations. The character of the blood in those bodily functions, if it's bright red, if it's darker red, or getting kind of, a bit less each time, is also important. And checking in with your healthcare provider to say, listen, this is what I'm experiencing. Is this normal? Is really important.
Thank you. The next question is kind of going back to the beginning a little bit more. And I was wondering if you could share just some of just general differences between kind of the more hereditary or family history type prostate cancer versus no family history or non-hereditary as it pertains to progression or how aggressive disease might be.
Sure. So genetic predisposition, we are finding more and more out about this day by day, month by month, with a lot of the research that's coming out. We have great genetic tests that can help to clarify some genes at risk for individuals with a family history. As you can see in the screening guidelines that I showed, individuals with a family history should be screened a bit earlier. And the reason for that is there may be some individuals who are at risk of earlier development of prostate cancer, and in some situations, more aggressive disease with multiple family members who have similar genetics or similar development of prostate cancer. So it's all about early detection. And I typically say preventative as opposed to reactive. So engaging with your healthcare provider on an earlier basis, determining what the best time for screening for you, given your risk factors, is really key. And determining also if some of the other tests that can help to clarify your genetic risk as high, low, or intermediate, that may also be appropriate.
Great, thank you. Again, I'm trying to kind of group these together, so forgive me as I'm
Sure.
scrolling and my eyes are looking away. We have a lot of questions, so thank you for everyone for continuing to submit your questions. This one is specific to hydrogel. How long has it been available to patients? And forgive me, I can't remember if you
so it's FDA approved in 2018. It's been in research and development for much longer than that. And as you can see, I mean, it's a very highly utilized side effect mitigation technique at greater than 500 major cancer institutions in the country, with hundreds of thousands of patients, more than 220,000 patients being treated with this. So very robust therapy that's had a lot of clinically proven data for the benefit it can provide. Great,
thank you. Can you talk about any of the side effects that were found in those studies, or with the tons of patients that have been treated?
Yeah, are you talking specifically with radiation therapy or hydrogel?
With the gel, with the spacer.
Yeah. So in general, right, a very safe and effective minimally invasive procedure to do this. Some individuals describe a bit of pelvic pressure or pelvic discomfort. I typically will say individuals who have a gel placed may feel like they're sitting on something like a pea or a walnut until their body gets used to the gel. You will, similar to a biopsy, expect some blood tinge in any bodily function for several days afterwards, urine, semen, or stool. There may be pressure to urinate, urgency or frequency, and pressure to have a bowel movement are the most common sensations. Those typically are mild and limited over the course of a couple hours to a couple days. Some of the risks associated with the procedure, there's a very low risk of bleeding, as this is small needle punctures, a very low risk of infection. We do give an antibiotic at the time that you get the gel placed, and our protocol is for several days afterwards as a prevention. As someone who's a high volume provider here, the risk of infection is almost negligible. And then there is a risk of, placing that gel into an area where you would not want that gel to provide space. One of the lower risks, particularly with good technique and direct visualization, would be placement of that gel or leakage into the rectal tissue. In some situations, that can potentially delay radiation therapy or cause inflammation of the bowels. And in rare circumstances, would that ever require a procedure to address.
Okay. Thank you. The next question is asking the difference between the SpaceOAR hydrogel and the SpaceOAR View.
Yeah, so SpaceOAR hydrogel was kind of the first iteration of SpaceOAR. This is viewed best with a follow-up MRI. So when you get your gel procedure, typically before you start radiation therapy, your radiation oncologist will do what's called a planning imaging study to get all of the plan and the anatomy aligned. The SpaceOAR regular gel, or the first version, is requiring an MRI. SpaceOAR View came along because MRIs can be cumbersome to get afterwards, and doing a CT image in many cases is easier for you as a patient, and easier to also schedule. And if we can see that gel appropriately, there's no reason to not do a view. So our standard, unless there is a reason not to place a view, would be to put a CT compatible gel. Reasons not to place a view would be iodine allergy, sometimes pelvic hardware like a hip prosthesis that would make it hard to see on a CT scan.
Okay, thank you. This patient has had some nerve damage from a previous prostate cancer treatment and is wondering if you could talk about a more unusual or uncommon side effect that this person's experiencing, which is penile pain, which is this person does appear to have a prescription that is treating that pain. But if you could suggest any other possible options.
Yeah, so pelvic pain or penile nerve pain or pelvic nerve pain oftentimes occurs from either impingement or swelling upon the nerves. Without knowing the treatment there, whether that's a surgery or radiation, many of those types of therapies involve ways to reduce that pain signal along the nerve. So sometimes pill forms of medication that are neuromodulatory medications, sometimes injection therapies may be effective in that space, depending on how severe the symptoms are and what the treatment response is. Typically, like most things, we try to do things least invasively prior to going forward with some of the more procedural options. It may be helpful to meet with a pelvic pain specialist from that standpoint.
Yeah, absolutely. We talk a lot about who should be included in a multidisciplinary team, especially if you have access to a multidisciplinary team, of course. Thank you. So the next question, this individual is wondering if, bouncing again, so I apologize. Can a biopsy be done on a person who has had an artificial urinary sphincter received due to a partial prostatectomy from a BPH diagnosis?
So the partial prostatectomy, I'm assuming, is an incisional-based partial prostatectomy for enlargement. Urinary sphincter is a typically like a ring that sits around the tube that passes the urine out the urethra and can be controlled. Yes, biopsies can be performed in that circumstance. Obviously, doing an imaging study beforehand and sometimes doing this in a very targeted fashion with fusion imaging may help to avoid that structure or the implant that you have. And it's sometimes necessary to give additional antibiotics to try to reduce the risk of any type of infection, which should overall be very low here.
Okay. Thank you. Let's see. We have a few more minutes, so I will continue to read through all of these amazing questions for about 5 more minutes. The next question is, this person's wondering if you could speak about when after a prostatectomy and a rising PSA is I think this is a typo, but PSMA PET scan best to be performed, maybe the best time in which that should be performed?
Yeah, so there's not a hard and fast answer to this question. And what we typically look at there is when we track your PSA values afterwards, which is the main way that we know, have we gotten a good treatment response? We see PSA be at a certain level and come down to what we call a post-treatment nadir, the lowest level. That happens with radiation therapy as well as prostatectomy. When we see where those levels settle out to, we look over time, typically starting at about 3-month intervals, and we compare what is that value to the next 3-month interval and then subsequent 3-month interval. We look at what's called a PSA velocity, how quickly that is changing, which doubling time of that PSA or velocity can help to answer that question. If we're seeing a more rapid rise of that PSA, that can help to determine the time frame of that PSMA or imaging study. PSMA is something that looks at some specific proteins that are linked with prostate cancer recurrence. It's a special imaging study that involves some dye to highlight what areas may be involved with prostate cancer recurrence and how we can better clarify your treatment. So that would be, engaging with your provider to really look at that velocity metric and then determine the right time to get that study to detect something if it's truly there. Lower PSA values may be more appropriate for certain studies or imaging PSMAs as compared to others.
Great, thank you. The next question is an individual wondering if for low-grade cancer, if the use of seeds and radiation might be too aggressive of a treatment option.
Well, it depends again on kind of a shared decision-making approach to what the goals of therapy are. With low-risk cancer, it depends on the volume of disease, how irregular that tissue looks, and what some of those other risk factors are. PSA changes over time, family history, genetic testing. So those are kind of the comprehensive pieces that we would use to really engage with you to say, listen, a treatment is necessary or is not necessary. There are some genomic tests that can be done as well on biopsy samples that can also help to clarify, are the genes associated with your prostate cancer of low, intermediate, or high risk? That can also help to clarify, is a treatment really worthwhile or appropriate in that type of scenario, or is this something that may be safer to watch?
Right, thank you. We get this question, I would say a fair amount, and I think it's a common question among all cancer types. But this individual is wondering if a biopsy can actually cause prostate cancer to spread.
So we have no conclusive data to say that that is the case. The reality is with small needle puncture there with a hollow bore needle, the prostate cancer is typically contained within the needle. Sample is grabbed and then basically pulled out. That's not been associated in any of our data sets with a spread of the prostate cancer.
Great, thank you. I think this might be our final question. We'll see. This question is wondering if you could speak on any possible elevated cardiovascular risks for either radiation or for hormone therapy.
Yeah, so again, a case-by-case personalized kind of risk determination there. Radiation therapy, particularly radiation therapy that's focused towards the prostate or the pelvic area, should not really beget any elevated cardiac risk. Obviously, when you're going through any type of therapy, we engage not only with, your cancer or your oncology providers, but also your other physicians who work with you to try to do this in a more comprehensive fashion. Same thing with hormone therapy that is sometimes given alongside radiation therapy or surgery in some situations. It's a risk benefit of giving medications that reduce testosterone and some of the other hormones that may affect cardiovascular risk. It would be important to know what overall cardiac conditions you have, work with your cardiologist to determine your specific risk, and if a hormone therapy is appropriate side by side with your radiation.
Great. Well, thank you. And thank you for letting us pepper you with questions. We left about 20 unanswered, so we had such great participation. Thank you to all of our attendees. Thank you again, Dr. Laganosky, for being here, sharing your expertise and your time with us this evening.
Absolutely my pleasure. And again, thank you all for taking the time to be here for the webinar. Again, my take home point would be, if there is something bothering you or you're concerned about a family member or friend, meet with a healthcare provider. Have us work with you and work in a shared decision-making approach to really help us to help you.
Yeah, absolutely. Such amazing advice. We talk often about shared decision making and being an involved advocate and empowered patient in your healthcare decision making process. So thank you for helping us drive that point home. Really quickly before we say good night, we did have some questions about whether or not the slides would be available. The recording will be available tomorrow in an email. You'll also receive our short survey. Thank you for filling that out. I'm going to thank you in advance because I know you're going to do it. And then the recording will be placed on our website in the coming days. And lastly, don't forget to join us tomorrow for our part 2 of this series, and we can ask more questions of our expert tomorrow, which will be moderated by my colleague Jeremy Patch. So we look forward to seeing you then. And with that, I'm wishing everyone a happy and healthy evening, and we'll see you soon. Thanks for being here.